Okay. Okay, so I'm just going to flip through it again. We're here on Friday. Ideally, it's the last time we're talking about these things. So where we left off on Wednesday was we got through all of this the previous day. We talked a lot about theories and explanatory style. And then we really ended by talking about evidence-based intervention. So CBT, what would we do there? And I kind of slowed down and talked, we skipped these videos, but from this point, I kind of slowed down and talked about how I might talk about emotions and kind of the steps of CBT to a younger child. And these are some of the resources that I have personally used before that are online and free. Same thing here. And then I don't remember if we talked about IPT. We're gonna breeze through it regardless. So remember, we talked about two evidence-based interventions for youth with depression specifically. The video that we watched highlighted DBT as well, and we're gonna save that when we talk about personality disorders, because again, that was designated as more of a like meant for more severe emotional dysregulation. But certainly if you have more severe depression, for example, then DBT skills might be helpful. So we're only going to focus on IPTA for the last evidence-based intervention for teens in particular. And this is an intervention that had the adult version was available first. So just like CBT, which was primarily made for adults, there was a downward extension to its use with youth. So IPTA stands for IPT for depressed adolescents. Again, as I said, it's a downward extension of IPT. And what we mean by downward extension is that it's adapted to be done with youth. And then there's some more developmentally sensitive, um, like theoretical, like the way that it's done is using some of the development in mind. And the fact that if it's teen, we're also probably dealing with parents. And so the parents become an important part of the intervention. Um, I'm going to, okay, so I treat depressed teens with IPTA. So this is just another evidence-based modality that's not CBT, but it incorporates aspects of CBT. Again, if we've seen that it's working for adults, there's a lot of evidence base for that in terms of the research. What's cool about IPT is that it's more interpersonally based, so it really is focusing on the child's or the teen's environment and how that might be contributing to depression. It's a brief intervention, which similar to CBT, like the manualized version is supposed to be like 12 to 18 weeks. And I believe IPT is similar. In practice, though, people are not like petri dishes, right? We're not like the people that are done in randomized control trials where it's very stringent. So oftentimes people go beyond the 12 to 18 months. But in terms of the research, it's brief and it's intended to be 12 to 18 weeks. Active skills teaching, and then there's homework activities that are pretty unique to IPT. So in general, who is this for? For about 12 to 18-year-olds, so really preteens up through teens. Um, Starts with 12 weekly sessions, and then as far as like what's the theory behind this? Because remember, we talked about CBT, cognitive behavioral therapy. What's the theory behind that? So cognitive theory, behaviorism, those are the aspects underlying that one. So for IPT, we're really taking into account attachment theory, interpersonal theory, and social theory. So again, like really encompassing the environment and some more of those close relationships like parents. There are three primary targets of targeting depression um, that are like the interpersonal problems associated with depression. So one of them is, of course, to reduce the depressive symptoms. We are hoping that depressive symptoms will reduce first and foremost. And then with that, we also are hoping to improve some of the interpersonal problems that are going on in the child's life that then maintain the depressive symptoms. And then again, we want to bolster social support because this is a really interpersonal based intervention. Uh, I won't read all of this. Basically, the idea here is that we care about the psychosocial and interpersonal context. That's how depression arises. And just as we think about mood, behavior, and feeling, or yeah, emotions, thoughts, and behavior all being like in a reciprocal loop, like in CBT, same thing applies here where we add in relationships. So how we feel impacts how we interact in our relationships, how our relationships are going also interact how we feel. And so this reciprocal loop, if there are some deficits or problems happening in either mood or relationships, that's cause for maybe looking at IPT as a potential intervention. It's designed differently, so we're not necessarily taking a specific event that happened and then using cognitive restructuring and saying, what are your thoughts, feelings? Can we alter that? Is there evidence for that? Instead, we are focusing on 4 interpersonal problems. So I think it's like session 2 maybe, or session 1, you're like meeting the person and you're starting to gauge like what's the core interpersonal problem area that we think is impacting depression here. So there's 4 different types: grief, role transitions, role disputes, and interpersonal deficits. I'm not going to talk about what they are. If you download the slides, there's notes on there for each one, but these are generally the 4 problem areas. And then we pick one to really start treatment with. And so there's a bunch of different activities. We agree upon the formulation. So if we do, okay, role transition. So if the big thing in someone's life right now is, I don't know, like mom just got divorced and remarried, and now we have a new step parent in the family. That transition from being like a whatever 3-person household within this dynamic has now changed to a new dynamic with this other person, and let's say the child's having interpersonal difficulties with mom and step parent. That might be like a role transition kind of example. So that's all I'm going to cover. It's an interesting intervention, and you can find stuff online if you want to look more at it. But I want to quickly wrap up evidence-based intervention for depression. So we're going to end with psychopharmaceutical medication. So when we're talking about depression, the things that you'll hear most often being prescribed and that has evidence base is fluoxetine and I always have a hard time saying this. These 2 medications, so SSRIs, are the ones that we typically prescribe, or psychiatrists prescribe this in general, so for depression. However, something that's noted is that there's less data in terms of what's out there that's available in terms of data for children, teens, and adults. So there's less data out there for kids in general, and with that, there's less evidence of the long-term effects of SSRIs on children and adolescents compared to what we know about adults. So it's still prescribed as a medication. There's nothing wrong with it, and in a lot of times it's helpful. But in general, what we view in the psychology field is, and what we see in the evidence, is that a combination of the 2, or CBT alone, or some sort of psychosocial intervention alone, is going to be superior to just medication alone. So in other words, we would recommend, if you're depressed, either medication plus the intervention, CBT, IPT, whatever it is, or just the intervention alone. And the reason we say that is because in terms of long-term effects, oftentimes people find that medication is helpful for especially when you're like severely depressed, really hard getting out of bed. The behavioral activation that we try to do in therapy is maybe like there's a link, like there's something missing, like they're bought in, but they can't get themselves to go on a walk, like we've said. A lot of times that might be answered with an SSRI, and that can help like boost, just get them going. But that doesn't often carry on long term, 3 months, a year, 2 years from now. So a lot of times it's really the therapy that's going to help maintain those gains that you might see with medication, which is why we're saying a combination or the intervention alone, and keeping in mind that you might see slower progress with intervention alone, but in terms of the research, we see that these 2 conditions are superior than medication alone. Okay, so looking at time, this is here in the PowerPoints. I'm going to skip this for now. These are just some interesting case examples. They come from APA as well. So just 2 different examples of a 15-year-old female and a 15-year-old male presenting for different reasons, but both diagnosed with depression. So if it's of interest, take a look. I want to cover suicide, which I've been saying since Monday that we would cover on Wednesday. So here's your warning that we're going to be talking about suicide. And we'll be pretty brief, but it's an important part of therapy. If you're working with a client, it's always important to assess whether or not there's any risk of suicide, if there's any suicidal ideation, whether it's active or passive, and in any so basically no any self-harm, so non-suicidal self-injurious behavior. Do we see any of that going on? And a lot of times when someone is depressed, we often assess this because it's one of the criteria as well when we're looking at MDD. The last criterion is if there's any active suicide attempts, has there been a suicide attempt, is there any ideation? So it is a criteria that we look for in MDD. Okay, so in terms of suicide, um, I'm not going to read all of this. Just note that suicide is one of the leading causes of death in adolescence. There's a quite a bit of range though in terms of what the suicidal behavior, thoughts, and actual attempts look like. So like, is it a completed attempt? Did they have a plan and a means? Did they have a plan but no means? Are they self-harming? So just know that there's a lot of things that we account for when we're looking at suicide in the research, but also clinically. Um, if you're not familiar, NSSI, non-suicidal self-injury, is intentional harm to one's own body. And it doesn't have to happen necessarily because someone wants to die. A lot of times, we might see cutting, burning, hitting, biting, like those kinds of things can be very punitive. So sometimes people feel strongly about like punishing their body or whatever, punishing themselves because of some other things going on. Sometimes it is an attempt, like I'm not going to attempt suicide, but I'd rather like have control, like I'm going to do self-harm instead. And sometimes it's just to feel in control or to kind of transfer a lot of the pain into something like tangible. So there's a lot of different reasons, and determining the function is really helpful. In DBT in particular, I've done a lot of chain analyses of what's the function of a certain NSSI behavior. It's saying here in the textbook, tends to be rare in children, but increases during adolescence. Anecdotally, I've seen that. Again, that's not to say that it doesn't happen in children. It just really tends to go up with age. Some important takeaways. So means reduction makes a difference. So just even if someone is, not actively suicidal, there's there's no means, they've never attempted, but there's like a pretty strong urge. Just for limiting access to anything lethal can be really helpful. So for instance, if I learn that my client teenager is like has a plan or just has suicidal ideation, even if it's like not that strong and I think it's going to be helpful, I might just advise like, can you put away any of the stuff that they might be using? So I'm working with an adult right now who her method of self-harm is burning herself, and she'll use lighters, curling iron, like anything like that. And some of those things are like, so like an iron, for example, might be necessary for the household. But as far as like those little lighters that you can just like keep repurchasing, I've had her like remove them from the car, remove them from your bed, like can that you put them in like a central place in the house, like you don't really need a lighter. You could use matches technically to like light a candle if you need a candle. So really just trying to like um, remove any of the possibilities that that's a method that could be used. Something that people get a little squeamish about, and this is in the general public, but also for early clinicians, people who are in training, is that they feel worried about talking about suicide. And there's concern that talking about suicide might increase or contribute to someone committing an attempt or having ideation or self-harming. And that's not true. So talking about suicide does not just automatically increase the risk that someone's actually going to attempt. And in fact, by making it not a scary thing, by calling it what it is, so naming it and saying, did you attempt? Okay, what was the plan? Or do you want to kill yourself? Like those kinds of things, being very frank, makes it actually much easier to talk about in a therapeutic setting. And we're not skirting around it. We're not saying we're scared. I actually care a lot that you're here and alive and safe, and I want to see you next week. So I'm going to ask you very direct questions. And so that's something that we try to remember, especially for people who are, earlier in their career, like grad school. who might feel worried about this. In terms of risk factors, a previous suicide attempt is like one of the most significant risk factors for a future suicide attempt. So if I know you have an attempt history, I'm going to be assessing this pretty regularly, and I'm going to be talking about it pretty clearly. So again, in DBT, we track with the diary card. I'll show you guys this all in like a few weeks. On the diary card, if there's self-harm, every week they're tracking. Did I have an urge? Did I act on it? And then if they do have any yeses on that card, then we're talking about it in the session. And that's like pretty agreed upon, pretty standard. So I'm just looking at the time. Okay, so assessing suicide risk, again, as I said, like you don't really want to skirt around it, but we recognize that it's a sensitive topic. So if you're, let's say you're doing an intake or you're just doing an assessment, you might say, like, so I'm going to ask you some questions that might be a little bit difficult for some people. Excuse me, I've said, like, it might be hard to talk about. A lot of times people don't want to talk about it. And I think it's really important. Like, I'm here to help you. I'm here, I care that you're alive. And I know you really want to work on XYZ, why you came into therapy. And so I need to ask these questions. Um, Something that's important is by speaking in I was going to say double negative. Double negative is not the right word. By making a question almost rhetorical where the client can't answer, that's not very helpful. So saying things like, "You're not suicidal, are you?" can lead to them saying, "Oh, no, I'm not." And it can be hard to disclose to begin with for that person. And so saying your phrase in a way that conveys no might not really be that helpful. So even with the diary card where I have to like every week track this whoever my client is with DBT, even though if they haven't done it, I go through it. Okay, did you do this? Nope. Great. Okay, we can move on. If there was a chance that I say, like if I say no self-harm this week, right? It's likely, and for this client that I have in my mind, she has a lot of shame around it. So if she can get around saying, no, I didn't do it, I don't want to talk about it, she will. So if I come in and say, oh, no self-harm, right? Like, probably not. She'll say, no, I didn't do that. And then that's a missed opportunity to discuss it, to talk about it. And so instead, flipping that to, did you do it? Or you tell me, let's look at it together. And she'll say, yeah, I did it. No, I did it. That can be helpful if you feel like you have a tendency to phrase it in a certain way that kind of leads them to answer. When you're assessing suicide risk in general, you're looking for recurrence. So, have they attempted in the past? What's the number of times? How did they do it? What were their circumstances? What's the symptoms of suicidality? So, that includes the desire and ideation. So, are they actively saying, I want to die, I want to end it, or is it more passive? Like, sometimes I feel like I'd rather not be here, or like sometimes I wish I could wake up or go to bed and never wake up. That might be a little bit more passive than active. I don't want to be here. Gosh, I can't wait to get out of here. Like that kind of stuff. And then resolve plans and preparation. So, do they have a plan? Do they have intent? Do they have means? Have they started preparing things? Um, I won't spend too much time. I'm not going to belabor this, but basically, suicide crisis planning shouldn't be, I mean, it's uncomfortable for sure. And I think, especially if you're going to work with a population that has higher risk. So a lot of the clients I work with, not who are these are more of my adult teen clients with high acuity, like this is going to come up quite a bit. And so, number one, on the therapist side, as you're like learning what populations you're interested in, if you feel like this is a hard, sensitive topic for you personally, then I think that's okay. And so just keep in mind, like different populations you work with might have this come up more. Regardless, whoever you're working with, if you are crisis planning, it's not something that you do for them. It's not, okay, here's a piece of paper, you're on your way. It's very collaborative. It's engaging them in the process of coming up with a plan. So if I have a crisis plan that says, okay, when you feel XYZ emotion that we know is associated with your suicidality, okay, call a friend. That's often on like a crisis plan. I could give them that, but that's not as thorough. So instead, okay, who are you gonna call? I'm gonna call Bree. Okay, what's the phone number? Well, I don't know. I'm just gonna, I just assume I'll find it. When we're dysregulated, sometimes it's really, really hard to have like the foresight to like, oh, let me go to my phone, let me find her. So I hear you. And I think it'd be really helpful to just have it written down. So let's write it down together. So it's collaborative in that way where we're saying, let's be honest with ourselves. If you feel it's often after dinner or whatever, then we might have that really tailored to that person, and what their signs are. The last thing here is remember limits to confidentiality. So especially if you're working with if you're working with a minor, you have to remember the limits of confidentiality. So oftentimes I'm not going to share really very much of what we talk about in our session unless I have concern about your safety or the safety of others. And so it's really important to convey like this might be really hard to talk about, and it's also not punitive if I do have to talk to your parents. It's because I care, and I'm also so if it's a younger person, like I'm an adult in the situation, so my responsibility, my job is actually to share with your parents. But can we figure out, like how much, like how you help me say to your parents, or maybe you want to say to your parents with me there, whatever you're comfortable with. So that might also be a way to help honor the confidentiality that you're going to have to break if it's related to suicide, and give them a little bit more autonomy so it doesn't feel like we're just ripping, the wool from their parents' eyes, for them and leaving them to kind of just hang with the aftermath. Okay, so that's suicide, finish depressive disorders. We're going to cover bipolar now. That's why I'm moving kind of quick. Any questions before we move on to our last section? I'm going to stop sharing this for a sec to see if I have any chats. No. Okay. Okay. So bipolar and related disorders are any of the disorders that contain mania, that's like the hallmark, as well as depressive symptoms. So if we're seeing depression, like the diagnostic question is depression, and then we learn in the course of the intake or whatever pair report that there's also been a period of mania, that's when we're going to pivot and look more at the bipolar and related disorders. So it can start off as depression, but as soon as we introduce mania, now we're looking at bipolar disorders. In terms of diagnostic issues, which is often important for looking at the research, looking at clinical utility, these questions or these issues that we talk about, it's important because it later informs what we see in some of the future versions of the DSM. And if they completely do away with the disorder or if they add a disorder, so it's actually important to talk about these issues. So one of the major issues in talking about bipolar diagnosis in young people is the degree to which child onset and adult onset presentations should be considered the same or different disorders. We kind of talked about this already in the mood section when we talked about DMDD, disruptive mood, something dysregulation disorder. And remember that disorder came out of this concern about diagnosing young people with bipolar because of the difference between child onset versus adolescent, which looks more like adult presentation onset. So there's just questions about what's the utility? Is it helpful? Is it really distinct when we say childhood onset bipolar versus DMDD? So let's just look at diagnostic criteria. Bipolar 1 criteria must have been met for at least one manic episode. And that manic episode needs not to be explained by any of these other disorders. So it's the primary criteria. Okay, yeah. So this is the primary criteria, but what is a manic episode? And so there's criteria for what constitutes a manic episode. So, manic episode is a distinct period of abnormally and persistently elevated, expansive, or irritable mood and abnormally and persistently increased activity or energy. And that period must last at least 1 week, and it has to be most of the days of that week. So nearly 7 days, most of those 7 days. Sometimes people are often hospitalized by that time, so that hospitalization counts even if it's like 5 days that I've been hospitalized, even though it's not a full week, oftentimes the hospitalization indicates that there was something happening and that was likely a manic episode. So that's the period. So the length of period it needs to be in existence for. And during this period of mood disturbance and increased energy or activity, 3 or more of the following needs to occur, keeping in mind that it needs to be 4 if irritable mood is going to be one of them. So inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual, or pressure to keep talking. So we call that pressured speech. Flight of ideas or subjective experience that thoughts are racing, distractibility, um, increase in goal-directed activity, excessive involvement activities that have a high potential for painful consequences. So those are the 7 optional symptoms, and 3 or more of them need to be present in order to constitute a manic episode. And then, of course, as we know, always needs to cause impairment, whether it's distress or it's impacting functioning, and it shouldn't be attributable to a substance. So we really need to pay attention, especially with manic episodes. Is it induced? Is it is it a bad trip? Are you on drug? Like, are you intoxicated? Are you under the influence? That might be different than this sort of manic episode. And it could well be like on a manic episode, you're in a manic episode and engaging in substances and that exacerbates it, but the manic episode still remains with or without substances. Excuse me. So let's look at mania symptoms in children. So remember, we're looking at these 1 through 7. So B1 through 7, keep in your mind. What does that look like in a child? So remember, we're always having to distinguish between normative behavior because a lot of these things fall within we're thinking of behavior on a continuum. Some of these things are pretty common in kids. So what sets mania apart in general and for children? So if we're thinking about elated mood, not a typical kid might just be very excited when the family goes to Disneyland on Christmas morning, right? That's just something really exciting happening. They might get really, really excited. Makes sense. That might look differently though than a child with mania where let's say a 9-year-old girl continually danced around the house saying, "I'm high over the mountain high." Or a 7-year-old boy was repeatedly taken to the principal for clowning and giggling in class when no one else was. Not a great example, but I think that's kind of the question is how do you distinguish between like pretty severe abnormal behavior versus what's typical? So I have a hard time with these examples. I've not worked with a child with mania, but that's what the book says. Grandiose behaviors. So a 7-year-old pretending he's a fireman when he's playing and directing, the play, like pretend play, basically. Pretty age appropriate, not impairing. 7-year-old boy steals a go-kart. He knows it's wrong to steal, but doesn't believe it's wrong for him. He thought the police were arriving to play with him. Keeping in mind, let's assume no other like intellectual difficulties, like can be pretty bizarre. And it's grandiose because like the rules don't apply to me, and actually the police are here to play with me, not to say this is something wrong, even though I know it's wrong. Hypersexual behavior. Here's an example. Yeah, so this comes from your book, and then this is the other table from the book. So this is like a pretty exaggerated like video clip, and it's intended for like, it's intended to be helpful for educational purposes. So I'm going to play it, but keep in mind it's like a pretty exaggerated, like clearly a skit, if you will. So, but let's just watch it to keep it in our head. Okay, an ad's playing and then I'll share it again.
Hello, I'm Dr. Steven Sisto, Chief of the Division of Child and Adolescent Psychiatry at the University of Texas Health Science Center at San Antonio. Many clinicians are worried about diagnosing mania in children. The big question is, how do you tell manic symptoms from the normal mood swings or the normal exuberance of childhood? In this following video, we see a girl, Rebecca, who is in acute manic state, and this shows you the severity of mood swings that can occur. Rebecca, how old are you?
I'm 12.
Did you just think of something funny?
Not really.
And how are you doing in school?
Awesome. We had a race in PE, and I ran faster than anyone else in the grade. I think I broke the school record. I ran into one of those hurdle things and went splat on the ground. Everybody was freaking out.
Did you hurt yourself?
There was some blood, but I like to see blood. It's really cool.
And how are you doing in class?
Real good. The work is super easy.
Your mom says you're failing a lot of classes.
Students don't know how to teach. I tell them I did all my work, and they say that is wrong. What do they know?
You get in a lot of arguments with adults?
No, they get in arguments with me. Do you know that song that goes, I like going 3 tomatoes?
I do not. Have you been getting in trouble at home?
No.
And your mom says you got grounded for throwing a ball at her head.
That was just a joke.
Let me ask you about your moods. Do you always feel as good as you do right now?
Oh, yeah.
And how long has that been going on?
Forever.
And how do you feel about yourself? Do you like yourself?
I'm a great dancer. I'm going to be the star of the school musical.
And do you have any other special talents, things other people don't have?
When I close my eyes, I can hear people's thoughts.
And what do you hear?
I can hear the teacher saying she's not going to make me take the test because I know it already.
And is it like a voice out loud in your head?
Sometimes.
Are you hearing it now?
No.
You have a lot of energy?
My mom says I'm the energy after bunny.
Very good. Do you do that in class?
Oh, yeah. It's so funny. When I dance, it's a fancy dance. A fancy dance. A fancy dance.
Whoop.
Ugh! I hate this. Stupid thing is broken. My mom is always buying me junk.
Let me have a look. Here, I think I've got it.
Great. Thanks.
All right. So, yeah, I think that's an interesting video, and I think some questions that come up for me, and I don't know, you guys can say so if anything comes up for you as well, is how does this look different than ADHD or like, pretty extreme hyperactivity? And how is this different than and we don't see it as often, remember, it's pretty rare, but schizophrenia, if we're seeing some delusions of grandeur or like some, I hear things. So I think those are questions you're asking regardless. So we always want to rule out other disorders. So that's the differential diagnosis. But those might be things that we might look at in this particular child. It feels pretty hyperactive, pretty like thoughts are racing. At least I'm perceiving it that way. But those are some things we might consider as we're diagnosing. The other thing to remember too is that this is in the context of a manic episode. If the child's like always always like this, then that might signal more something that's not a manic episode. It might be more indicative of ADHD if we're looking at the criteria, and that seems to be more explanatory. Same thing for schizophrenia. So this is in the context of a manic episode. And with bipolar, we're not always in a manic episode. It's a very discrete time period. So this would be a difference from how the child usually is, which I think is a way to help us kind of pull apart the questions that we have about ADHD versus bipolar or something else. Okay, if no other questions or no questions at all, I'm gonna keep going and see how far we get. I think we only have like 8 slides, which is good. So we just watched this. That's just an example of what a manic episode might look like in a child. That's not necessarily bipolar 1 or bipolar 2. I just wanted to show that. So bipolar 1, we talked about as manic episode, discrete period. Those are all the characteristics that would describe it. Bipolar 2 is different. And with bipolar 2, criteria must have been met for at least one hypomanic episode and at least one major depressive episode. If we're going to diagnose bipolar 2, there needs to have never been a full-blown manic episode. At least one hypomanic episode and at least one major depressive episode are not explained by XYZ, all these other disorders, and the symptoms of depression or the unpredictability caused by frequent alternations between depressed mood or hypomania, of course, need to cause dysfunction or distress. So a hypomanic episode looks different than a manic episode. And this is important because with a manic episode, we're really looking at 7 days. It needs to be at least a week. unless there's some sort of hospitalization. But in general, you're looking at a full week, and that's a minimum. Hypomanic is different. We're still going to see it's an abnormal, distinct period of persistently elevated, expansive, irritable mood. Needs to be occurring for most days, but that period is going to be 4 consecutive days. So as soon as it passes 7 days, we're in a week's worth of period, and now we're moving into the manic territory. A lot of this is the same. So 3 or more symptoms need to be present during this hypomanic episode. These are, I believe, nearly identical. I'm going to skip over C and D, but E is important. So this hypomanic episode is not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization. So it's concerning because it's a departure from the child's usual demeanor and their activity level. So it's clear that something is happening, but it may not be severe enough to send someone to the hospital. So sending someone to the hospital often signals that something like pretty severe is happening. It's concerning, like they're maybe a danger to themselves or danger to others. We might see that more common with a manic episode versus hypomania. It's not quite to that level. So this impairment is there, but it's not nearly as severe. So in general, I pulled this from actually Shira has taught this class before. So I like her little table that I think is helpful for comparison. So if we're just generally looking at bipolar 1 versus bipolar 2, major depressive episode, you don't necessarily need for bipolar 1. The primary thing in bipolar 1 is that you have a manic episode. In bipolar 2, you do need to have had a depressive episode. And remember that there's also mania involved. In terms of a full-blown manic episode, you do need that for a bipolar 1 diagnosis, and it cannot be present for bipolar 2. So you cannot have that 7-day minimum of a pretty strong manic symptoms. And then for hypomanic episodes, it's not necessary for diagnosis of bipolar 1, but you do need it for a diagnosis of bipolar 2, in addition to that major depressive episode. So that's a quick comparison. I think it will come in handy for the exam when we have like a couple questions about like comparing vignettes and you're having to decide between bipolar 1 or bipolar 2. Oh yeah. Yeah. Okay. So just other etiological things to consider. What's the evidence base? So it's a highly heritable disorder. So we think there's a strong emphasis, or there is a strong emphasis on genetic risk factors in particular. We've talked about schizophrenia as being a highly genetic disorder. OCD, like those anxiety-based disorders tend to be highly genetic. Same with bipolar. There's a strong emphasis on shared genetic risk factors. So family member with bipolar, strong indication that someone else in the family might have bipolar as well. As far as evidence-based treatment, so with this, it's interesting. First line of treatment is pharmacotherapy, so medication, mood stabilizers, and antipsychotics. Most research looking at youth and what's the treatment for bipolar in youth have really focused on medication. That's the thing that's going to stabilize like these chemical alterations in the brain. That's really the frontline treatment. So that's the thing I would take away. It's really medication. There has been some evidence, but not strong enough evidence of family-focused psychotherapy as an intervention for children with bipolar. But it's not touted as like a strong evidence-based intervention. So if you were to ask, what's the frontline intervention or treatment for bipolar in youth or adults, I would say it's medication. But of course, like intervention techniques and strategies can be helpful just in general day-to-day life. So that's why we have here DBT techniques could be helpful for managing emotion dysregulation, things like that. Okay, how many slides do we have? Okay, so we'll look at this case study, and it comes from an APA website as well. And this is looking at a 19-year-old male. So Gary is a 19-year-old person who withdrew from college after experiencing a manic episode during which he was brought to the attention of the campus police. Something he has said in the past is, I took the responsibility to pull multiple fire alarms in my dorm to ensure that they worked, given the life or death nature of fires. He had changed his major from engineering to philosophy and increasingly had reduced his sleep, spending long hours engaging his friends in conversations about the nature of reality. He had been convinced about the importance of his ideas, stating frequently that he was more learned and advanced than all his professors. He told others that he was on the verge of revolutionizing his new field, and he grew increasingly irritable and intolerant of anyone who disagreed with him. He also increased a number of high-risk behaviors, things like drinking and engaging in sexual relations in a way that was unlike his previous history. At the present time, he has returned home and has been placed on a mood stabilizer after a period of time on an antipsychotic, and his psychiatrist is requesting adjunctive psychotherapy for his bipolar disorder. That just means that's in addition to medication. The patient's parents are somewhat shocked by the diagnosis, but they acknowledge that Gary had early problems with anxiety during pre-adolescence, followed by some periods of withdrawal and depression during his adolescence. His parents are eager to be involved in treatment if appropriate. So, symptoms that we're seeing here, number one, it's a departure from his usual functioning. Clearly, it's different from what he's done before. Parents are surprised. That's an indication that this is like a departure. Um, I'm trying to see. They're like, again, this is a case vignette for bipolar, so they don't say specifically how long he was experiencing these symptoms, but it's saying a manic episode, which indicates to us it's been at least 7 days. A lot of these behaviors that he's doing cause concern. So he's engaging in risky behaviors that can be really concerning. Drinking, right? So it doesn't say here, but if you're drinking and you're manic, you may be you may be driving drunk, which is like a danger to yourself and others. Engaging in sexual relations, like that is not necessarily in and of itself a problem, but if it's a departure from usual, if you're being unsafe, like you're raising your risk of contracting a sexually transmitted disease, you're pulling firearms, right? That's like that delusion of grandeur, like I'm saving the world, I'm revolutionizing the field. Things like that feel really different. And just reading this vignette, it feels like this person is probably like on a motor, constantly thoughts racing, very exhausting to probably talk to. So those are the behaviors, symptoms. Um, any questions about that one? Do you see anything else that's worth looking at in this one? Or something that, yeah, is interesting to you? No? Okay. Let's look at this last one then. And I put this one at the end because it's an 11-year-old. And I don't have a symptom slide, so maybe people can point out what the symptoms might be. It's not letting me zoom in. It's like frozen right now, so I'm just going to read it. So Ansa is an 11-year-old girl who lives with Mrs. J, her mother. Her parents have been divorced for years, and she has little contact with her father. Ansa's early childhood history was marked by her mother's numerous unstable relationships, which led to the mother and daughter moving many times before Ansa was 7. Ansa was unknown to any child psychiatry service. From age 6 to 8, Ansa was on methylphenidate for suspected ADHD. There were no beneficial effects, and the medication was discontinued. Otherwise, Ansa's past psychiatric history is negative. She's never had physical illness, never taken drugs or alcohol or medication. Family history is positive for Mrs. J's borderline personality disorder and her uncle's possible but unconfirmed diagnosis of bipolar. So this first paragraph is important because this is literally all developmental psychopathology. This is what is the early risk factor, what are developmental risk factors. So we have shared family history of mental health problems. So it doesn't matter what it is, but mom has mental health problems, and it's pretty strongly suspected that uncle has bipolar, which if we think back to the genetic risk factor, strong heritability if one family member has bipolar. So just already developmental risk factors are kind of like our bells are going off, right? So she's had many moves, that is potentially a risk factor. The instability in her environment pretty early on. Single parent household basically for many, many years also serves as a risk factor. her own mental health history, so early suspicions of ADHD, being on medication, didn't work out. So a lot of this, if we plug this into the DP model, we're seeing a lot of risk factors. We're seeing how mental health problems probably arose for this particular child. So now Ansa was admitted to our service. So this is from a research article and I think the researchers are clinicians at like a hospital in the UK. So Ansa was admitted to our service for grandiosity, agitation, and distractibility that had appeared in the last 2 days. She had no sleep, spending the nights cleaning her room. She had excessive projects, including becoming a rock star. These symptoms rendered her totally unable to attend school and even take care of her basic needs, such as hygiene. There were no recent stressors. The MSE, so the mental status exam, showed a child unable to remain seated, so spending the whole interview moving object to object. She had an irritable and labile affect, blah, 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 accelerated speech, flight of thoughts. She expressed countless projects, although there was no delusional grandiosity. She's denying hallucinations and suicidal ideation. Her tests, so these physical health tests all came out fine. Physical evaluation shows nothing significant in her physical health. MRI, so brain stuff looks good. So it's not like she has like a brain bleed or concussion or anything like that. At this point, she's now diagnosed with acute manic episode with no identifiable organic etiology, which means nothing like bodily. If we're thinking of like medical diagnosis, there's nothing medically causing this manic episode. Um, but with a possible biological vulnerability for emotion dysregulation. So that's paying homage to the genetic risk factor, the developmental stuff we always look at. So this is like from a legitimate art. This is a research paper. It's an peer-reviewed article, and this is a case example of a client that they saw there. So this is based on someone real. This is how she presented to their clinic. And I think it's a good example of developmental psychopathology and what this can look like in an 11-year-old, which feels really young. And yet this feels pretty indicative of bipolar. Could potentially look like schizophrenia, but in this case, they diagnosed bipolar. Okay. Any questions about that one or like thoughts about the case vignette or any of the other things we talked about? Concerns, questions about what this looks like in treatment with the suicide risk or any of the mood stuff? Okay. I'm gonna give you like 10 more seconds. If there's no other questions, we can just end early. Yeah, I'll answer this question, but yeah, everyone else is free to go. See you guys next week. If you understood, is it possible to have a manic episode without having it tied to a disorder? Yeah, so are you talking about the vignette that we just read where it says no organic etiology? Yeah, no, so it means, so it's kind of written weird because it's like UK British language. It meant that there was no like medical, like there's a brain concussion and that caused manic episode. So that's what they meant by no organic etiology. Organic refers to like biology. It is a disorder. So this is bipolar. If there's a full manic episode, that means it's in our terms, in terms of psychology, we would diagnose that as bipolar 1. They're just pointing out that these symptoms are not attributable to getting in an accident and having a TBI or having some sort of crazy, like, I don't know, something that like physicians like surgically might remove. So they're just saying that it's not anything like that, which is important for us to know because in the DSM for bipolar, there are certain, I think it's like criterion D and E, it says make sure that this is not attributable to the effects of a substance or some other disorder such as schizoaffective, and that would also include any of these like medical disorders. Does that make sense? Yeah, of course. All right. I'll see you all on Monday.